Good morning, everyone. It is my pleasure this morning to introduce the Jack and Nadine invited lecturer, Dr. Packer. I just want to say or take a moment to acknowledge Jack and Nadine, who have been such long-standing supporters of the division and have sponsored this lectureship for longer than I have been here, so 20 years. And I just, Milton and I were talking about this yesterday about, is there any importance to these type of visits anymore now in the age of Zoom? And actually, we sort of came to the conclusion they're actually more important than ever, because it's our opportunity to sort of interact face to face, and we get less and less of that. So I want to thank Jack and Nadine for doing this, and we really appreciate it. It's a great opportunity to bring people in. And I'd also like to thank Milton for taking a few days out of his schedule to come. Let me just say a few words about Dr. Packer. I met him actually as a fellow when I was at Baylor, and I was trying to figure out what to do. And that was early 90s, and so the clinical trials that were coming out in heart failure at the time. Heart failure was exciting as structural heart is sort of today. We finally had some tools, and it really sort of inspired me, which is why I went into sort of heart failure. And I always think when I'm on the wards and we talk about heart failure and the fellows say GDMT, you're looking at one of the people who actually was instrumental in determining that. And he's really been at the forefront of therapies for heart failure. And if you've been in the field at all, you will know many of the things that he has sort of contributed during that time, which he's going to give us a historical perspective today. But I'll just say one other thing about when I've always seen his talks, I'm impressed because as a clinical investigator, he's really sort of analyzed the data. And what I really appreciate is a fresh take on things and a new perspective in looking at things. And, he was instrumental in developing the neurohormonal hypothesis, but I still torture the residents when I'm on rounds about comprehensive neurohormonal blockade. And I stole that from a talk that Milton gave many, many decades ago. So thank you very much, Milton, for coming. We really appreciate it. We're looking forward to your talk.
Thank you so much. So I am really delighted and privileged to be here. My great thanks to Jack and Nadine. This is just unbelievably wonderful. I want to tell you that the last 2 days have been glorious, but I will tell you the best part is spending time with the fellows. It has been magical. And, honestly, I could do this for another couple weeks, but you guys would be really bored. So just to let you know, it is. So what I'm going to try to do is I'm going to try to tell you a story. Hopefully it will not be a bedtime story. The goal is to give you a perspective, and I'm going to give you a personal perspective. So that's why the talk is called 45-Year Journey, but I am not going to start 45 years ago. What I'm going to do is to remind you that this is probably the most common chronic disease that afflicts mankind worldwide. And 1 out of 3 people will develop heart failure during their lifetime, and it causes more deaths every year than all cancers combined. It's been around a long time. It's the oldest non-infectious, non-traumatic disease in human history. Significant evidence in Egyptian mummies. There has been writings about heart failure in Babylonian and Sumerian tablets. In all of these descriptions, the primary symptom of heart failure was fluid retention. And heart failure wasn't known as heart failure because at the time people didn't know it was a heart problem. They knew it was a fluid retention problem. And so they called it hydrops or dropsy. Essentially, terms for fluid retention. And the person who really put it all together, who no one ever talks about, is this man. This is Albertini, writing in the 16th century. He decided that heart failure represented some involvement, deranged involvement between the heart and the kidneys. And everyone at that time thought he was a little crazy because no one actually thought that dropsy, hydrops, had much to do with the heart. But he actually made some very meaningful scientific observations. Much of his work has actually been lost in the discourse over the years, but his work laid the foundation for a dominant theory of heart failure for several hundred years. This was the cardiorenal hypothesis of heart failure. Essentially, if the heart didn't work, then it didn't pump blood to the kidneys. And if it also caused renal congestion, the kidneys would rebel and hold on to salt and water in an attempt to maintain circulatory homeostasis. That was the theory. Sodium retention by the kidney would lead to edema. Edema was the physical sign of heart failure. And what was really interesting during this time was that the emphasis on fluid retention was so dominant that the only treatments that people cared about were treatments that produced a diuresis. And you might say, that's not true. William Withering discovered foxglove for the treatment of heart failure in 1785, but Withering thought that foxglove was a diuretic. And so diuretics were the dominant theme. Then people developed other diuretics, 1920s mercurials, oral thiazides in the 50s, loop diuretics in the 60s. And all of this was to take the patient from a decompensated state to a compensated state. Now, this was a sort of really interesting concept. Decompensated meant that they had fluid retention. Compensated meant they didn't have fluid retention. And if you had compensated heart failure, you didn't have progression. You only had progression when you had fluid retention. So what most physicians were taught is this is how heart failure works. You see, you have a very, very stable problem. It's called compensated heart failure. Intermittently, you have fluid retention. And as long as you get rid of the fluid retention, the patient will be fine. The only problem is that this is not what happened to patients. What happened to patients is that they did get intermittent fluid retention, but they got progressively worse over time. This was a progressive disease. But the concept that heart failure was a progressive disease is only 40 years old, which is extraordinary. I remember having debates in the late 1970s with people who would say, oh, you're trying to treat a disease which only occurs when patients develop fluid retention. And so the concept that this was a progressive disease meant that there had to be something going on other than fluid retention. And the upshot of that was that the prognosis was dismal. Even if you treated the fluid retention, this was the survival curves in 1975 for class 3 and 4 heart failure. And you can see in 18 months, more than 50% of patients had died. And that was the state of heart failure when I began my cardiology fellowship. It was all focused on the treatment of a volume expansion based on a framework. And the framework was the cardiorenal hypothesis. Remember, physicians treat diseases based on the stories they believe. So if you think that the cardiorenal hypothesis is true, you treat patients according to that. It may be a false story, but that's still what dominates thinking. So there was a change. In the 1970s, two events occurred in cardiology almost simultaneously. One was the advent of echocardiography. Second was the advent of bedside hemodynamic monitoring. They all occurred pretty much within a 3 to 4 year period of time. And all of a sudden, people who were interested in heart failure could do two things. They could actually see the heart, measure things, and they could measure pressures inside the heart. And that opened up a universe of possibilities that previously had never existed. And that universe was synthesized into a new conceptual framework. It was called the hemodynamic model of heart failure. To tell you the truth, it wasn't particularly sophisticated. When the heart didn't work, it didn't pump blood forward. It didn't really, it failed both in a forward direction and a backward direction. Well, if you fail forward, you don't give blood to the kidneys. Fail backwards, kidneys get congested. You hold on to salt and water. But at least this was a concept that became apparent, not because we were smarter, but because technology allowed us to measure things we couldn't measure before. And this hemodynamic model was the model that I started with. Whole concept was, well, there was a Frank Starling relationship. Everyone thought they understood that. And in heart failure, that Frank Starling relationship was shifted downwards and to the right. And so that cardiac output was lower, filling pressures were higher. And the whole goal of treating heart failure was to give drugs that would make the heart go forward better and allow blood to return in a less congested state, and that would shift the Frank Starling curve upwards and to the left back to a normal curve. And people thought, if you could do that, you could treat heart failure. All you had to do was take an abnormal curve, make it normal, people would get better. And so the focus was the heart as a pump. And that hemodynamic model was a dominant theme. People could make great measurements before and after treatment, and they did that. The whole goal was, if you concentrated on making the heart numbers better, you could slow the progression of heart failure. Well, we would do that. We could give intravenous vasodilator drugs and cardiac output would go up, filling pressures would go down. We could give positive inotropic drugs. We could achieve the same thing. We could give them intravenously. We could give them orally. Everyone was just unbelievably happy because we were in love with the numbers. but not with the outcomes. And we thought, God, you know, cardiac output just went up from 1.9 to 2.7. We would walk into the room, we would say to the patient, don't you feel better? And the patient would say, no. I said, no, you're wrong. You must feel better. We have data that says that you must feel better. How ungrateful could you be that we have made your hemodynamic numbers better and you, for some reason, can't appreciate this? And we saw this phenomenon all the time. We said, oh, well, they're actually getting better. We put people on these drugs and they can exercise more and their symptoms get better. The only problem with the studies that I'm showing you is they all consisted of about 10 patients without a control group. And God, you give me 10 patients without a control group and I can prove to you almost anything works. So at this point in time, I was a second year fellow in cardiology and at Mount Sinai Hospital, and right next to the fellows room was the editor of the American Journal of Cardiology, which at that time was the official journal of the American College of Cardiology. Simon Dack had his office there. And when he would get all of these papers, and Simon Dack didn't have 40 associate editors. Simon Dack had one editor, and that was himself. He would get all the papers, he would read all the papers, and if he had a question, he would walk into the fellows room and he would say, can you come with me and read this paper with me? And the fellows would do that. The fellows would say, why is he yes? I don't know anything about this. And he would hand the paper and he would say, does this paper make sense to you? And if we said no, he said, well, we're going to reject it. And we would say, but we don't know anything. So we see that's the point. You should be able to understand, if it actually makes sense, you should be able to understand it without any presumptions that you should know something. If it is so crystal clear, then your background doesn't matter. And I thought, oh my God, what an amazing concept. And so vasodilator therapy was just coming into its into being, and he had a couple papers and he knew I was sort of getting interested in heart failure, and he said, what do you think? I said, I think all of this stuff it's disconnected with how patients feel. And he said, okay, you're going to write an editorial on that. I said, I'm going to what? He said, you're going to write an editorial on that. And I said, I have never written a scientific paper in my whole life. I have no idea how to do it. Is an editorial supposed to be fiery and rebellious? And Simon said, well, it could be. But he says, just tell people what you think. This was my first paper. A plea for caution. Jose Meller, who was head of the Echo Lab, helped me write it. He helped me write it because he came from Chile, said that English was a terrible way of expressing thoughts. He translated the paper into Spanish, made it absolutely gorgeous, translated back into English. That was what was published. So this was a paper that started, but what really started was this. I went to an American Heart Association as a first-year fellow. There was a poster on vasodilator therapy. I spoke to Joe Franciosa, who was at the University of Minnesota. Joe was giving drugs to people with a pulmonary artery catheter, and he said, and I said, gee, I can probably do this. There was a lot of enthusiasm at the time for a alpha blocking drug called prazosin or prazosin, depending on your preference. And all of the luminaries in the area of heart failure were touting this as the new major advance in the treatment of heart failure. Lead article in the New England Journal of Medicine, many follow-ups. And so I decided in March of 1977 to try to see if prazosin worked. And I gave one dose in which was exactly the same results as everyone else was publishing, because everyone else was just publishing the effects of one dose. And the next day, I measured the effects of a second dose. I thought, well, that's strange. It's a little bit smaller. And I measured it on the next day, and there was almost nothing. And I repeated this total study of 8 patients. Published this as prazosin tachyphylaxis. Took 13 months to get it published in Circulation. Why? Because they kept on sending it to the patient, to the luminaries who loved prazosin and kept on trying to find problems. The paper was published, and at the time of its publication, it was immediately condemned by every major figure in cardiology. And said the methods were terrible, conclusions were wrong, and probably most damaging, who is this guy? He's a first-year fellow. What does he know? He's never done this before. We've been around for decades. We built cardiology, and people should believe and trust in us. And they went around the country and amazingly gave hundreds of talks, always showed my slides and told everyone how terrible the work was. God, what an unbelievable lucky break. Because they took an obscure first-year fellow in cardiology and gave him a national reputation. Admittedly, it wasn't a favorable one, but they did me an enormous favor. Because if I had tried to generate that kind of attention for my work on my own, I would have been unable to do that. And so when I got up at a meeting at a microphone and asked a question, people would say, oh, that's the person who's making all the trouble. And as long as I did my homework, I could get up and I could say, the emperor has no clothes. And over time, prazosin didn't work. It wasn't just prazosin that didn't work. It wasn't just that the first dose became attenuated for prazosin. It also became attenuated with almost every vasodilator, became attenuated with intravenous nitroglycerin given continuously. And so tolerance was a big problem. The question was why? And so I began this sort of interesting experiment. I infused nitroprusside into a group of patients. You can see the group is not big, 20 people. There was an immediate hemodynamic response. At the same dose within 5 minutes, the response became attenuated. And if I took the drug away, there was a rebound phenomenon. And the patients got worse than they had before I ever gave nitroprusside. All these patients had chronic heart failure during nitroprusside rebound. 4 went into pulmonary edema. And the question was why? And the theory that was promulgated was that when you gave a drug, like a vasodilator, the body responded by a counter-regulatory mechanism that opposed the drug action. You could measure the counter-regulatory mechanism by the amount of attenuation, and you can measure it by the amount of rebound. And you could show that these two were linearly related to each other. It was the same phenomenon, responsible for the attenuation, responsible for the rebound. And the concept was a direct action of the drug. The net effect was the direct action opposed by the counter-regulatory effect. If you took the drug away, you only had the counter-regulatory effect responsible for rebound. Why? Well, people had thought that heart failure was a neurohormonal state since about the early 1960s, mid-1960s, but they thought that neurohormonal activation was adaptive. They thought that neurohormonal activation was essential for supporting blood pressure and supporting cardiac output, that the active increased levels of norepinephrine and angiotensin should not be interfered with. Because if you did, people would become hypotensive and people would go into worsening heart failure. But we tried to test this hypothesis with a variety of vasodilator drugs. Probably the most compelling was the work with this drug. Almost no one in this room remembers this drug. It's a drug called flosequinin. I knew Wayne would remember. What most of you don't know is that in 1993, the FDA approved this drug for the treatment of heart failure. And this drug was amazing. At the time of its approval, the drug flew off the shelves. Thousands of people were prescribed flosequinin, and the reason was when you could actually give this drug to a patient with class 4 heart failure, and 2 weeks later, they were class 1 or 2. It was amazing. People felt wonderful. Improved exercise tolerance, improved symptoms. It was really, really impressive. There was a problem. It kept on bothering everyone. It caused neurohormonal activation. Heart rate went up. Plasma renin activity went up. And we said, well, maybe that doesn't matter. So we did some additional work, and I had the great privilege of leading this trial called the PROFILE trial, double-blind randomized trial for flosequinin versus placebo, which was finished 3 months after the drug was commercially available in the United States. During this trial, the responses at 1 month were unprecedented. in a favorable manner. People really, really felt better. And when we followed them long-term, for a short period of time, they stayed out of the hospital more. And then when we followed them further, the flosequinone curve is in yellow, the placebo curve is in green, and the curves crossed. Patients initially got better, and then they got worse. All-cause mortality was increased by 39%. Trial was stopped early by the Data Safety Monitoring Board, and the drug was removed from the US market. No one has ever heard of that drug since. However, at the time of its withdrawal, there were about 1,000 patients taking flosequinone who refused to come off the drug, even though we told them this drug is increasing your risk of death. And they said, well, I feel so much better with it. And we said, oh, God, this is a problem. It wasn't just with flosequinone. Saw the same problems with other vasodilators, minoxidil, epoprostenol. And we then saw the same problem with other drugs that were hemodynamically effective, positive inotropic drugs, whether they were beta agonists, interacted with the beta receptor, or they inhibited the breakdown of cyclic AMP because they were phosphodiesterase inhibitors. Amrinone was the first of this new class of drugs, increased cardiac output, increased filling pressure, increased exercise duration, all uncontrolled data. And we took a look at it, and we saw something really interesting. Patients got better. Over a period of a couple months, they got worse. When we took the drug away, the drug effect disappeared. The magnitude effect here is the same as the magnitude effect here, but now they are here and not here. The drug accelerated the underlying progression of heart failure, and it was a phenomenon that was similar to that seen with dimutamine. We carried out the PROMISE trial in order to actually convince people that this drug actually had the potential of making people worse. And the PROMISE trial was stopped early by the Data Safety Monitoring because milrinone increased the risk of death overall in the trial, and particularly in patients with class 4 heart failure. So, this wasn't working. We had a model of this disease, that would have predicted that a whole host of drugs should have worked, and they did not work. And therefore, this is a classic example of bedside to bench. Everyone talks about bench to bedside. Well, you know, that happens. Doesn't happen all as much as often as you might think. But the real way that people learn is they do clinical research. They make observations in patients, uncontrolled clinical trials. They see what works, and they then go back and try to explain a clinical observation. It's the reverse of the direction that you might think. And when we had all of these negative reports with positive inotropic drugs in clinical trials, we realized we needed a new model of heart failure, but it wasn't a new model. The first person to ever put forward the neurohormonal hypothesis in heart failure was Nicholas Callicles, who was a Byzantine physician in the 12th century, who wrote, "In high drops, the problem lies in the humors." having abandoned the extremities, might move in some direction and endanger the patient's life. If we do not get rid of the humors, they will move to some vital organ, even to the heart itself. And if that damage happens, it will be irremediable. That's really the neurohormonal hypothesis. And the interesting thing about that was it could be demonstrated experimentally. If you gave angiotensin, norepinephrine to isolated hearts, you could induce adverse effects. If you then overload them, they would be more sensitive to the adverse effects of angiotensin and norepinephrine. And that led to this paper. This is the first paper to put forward the neurohormonal hypothesis. And it was based on the totality of evidence. And it begins very simply. When physicians think that heart failure is a hemodynamic disease, they use hemodynamic interventions. And, but therapeutic interventions may improve the hemodynamic state, but adversely affect long-term outcome. Findings have raised validity about the hemodynamic hypothesis, proposing a neurohormonal hypothesis, suggesting that pharmacological agents should be directed to the neurohormonal imbalance. These observations support the formulation of a neurohormonal hypothesis of heart failure for the development of new therapeutic agents. And when we put this forward, there was substantial, understandable pushback from the clinical community, because everyone knew that heart failure was a hemodynamic disease. But in 1992, the neurohormonal hypothesis began to gain traction. And the whole concept was, if we began to interfere with these neurohormonal systems, we could actually change the progression of heart failure. The first targets were the obvious ones: angiotensin and norepinephrine. Basically, the targets for ACE inhibitors and beta blockers. ACE inhibitors were introduced for the treatment of hypertension. And people said, well, maybe we should give it to people with heart failure. And the initial reports with ACE inhibitors in people with heart failure were disastrous. People became hypotensive, went into renal failure. UK regulatory authority said no patient should be put in heart failure, should be put on an ACE inhibitor unless they're hospitalized under close supervision. And the reason is that people were giving enormous doses immediately. Neurohormonal antagonists are typically given in a slow up titration process, because if you do that, time is on your side. This is a comparison of prazosin and captopril. Prazosin looks much, much better after the first dose hemodynamically, but after months, prazosin disappears. Captopril is getting better and better, and the same would occur with beta blockers. Beta blockers actually cause a modest decrease in cardiac output. Amrinone looks great. You come back 2 or 3 months later, amrinone has now deteriorated, and beta blockade is getting better and better. The drugs are titrated, initiated a low dose, titrated up slowly, and this was really a hard sell, because there were a lot of people who were told that beta blockers were contraindicated in patients with heart failure, because the sympathetic nervous system was really important in supporting the circulation. So there were 2 crazy people at the time. On the left is my good friend, Carl Svedberg from Gothenburg, Sweden. Carl was the first person to use beta blockers in an uncontrolled study, published in the late 1970s, early 1980s. And if you meet Carl now, he looks pretty much the same. He hasn't aged in all of these years. In contrast to the person on the right, who's gotten a little older. Carl and I tried to convince the world that this was a neurohormonal disorder, and the data started coming in. Carl led the consensus trial, first trial to show ACE inhibitors reduce mortality. There was a subsequent trial that I was involved with, the SOLVE treatment trial, also a reduction in mortality, but a lesser effect in a milder group of individuals. Beta blockers were really interesting because we needed data from controlled trials. And I had a postdoc named Henry Kroom who came from Australia to New York City. And he wanted to do a controlled trial of beta blockers in heart failure. And I said, Henry, that is really, really wonderful. We'd love to have you come here. I don't have any money to pay you. He says, I have a grant from the Australian government. I can stay here for 4 years. I said, well, we have a place for you. It's, this is Henry's work. This is the efforts of one young investigator who randomized about 50 patients, double-blind, placebo-controlled, over a period of 3 months. And in this single study, single center study, carvedilol was fantastic. Over 3 months, ejection fraction rose, symptoms got better. The patients were able to walk more, heart rate went down, of course, as a result of beta blockade. And this encouraged the company to make a additional investment. Carvedilol was originally introduced for the treatment of hypertension, and they started, well, maybe we ought to expand this to a multi-center experience, especially when we showed them these data. Now, these data might look really impressive, but you should not believe them because they're based on an unbelievable small number of events. And Wayne is sitting there shaking his head and realizing that if I showed this slide in 2023, everyone would laugh. But when I showed this slide in 1995, the company said, we're going to make an investment. We're going to show that this is real. And the US carvedilol trials were launched. And they reported a reduction in mortality of 65% over an average period of a little bit less than a year. Reduction in death and cardiovascular hospitalizations. This was subsequently confirmed with metoprolol by the Merit investigators, with bisindiol in the CBIS-2 trial. And then we got the chance to do Copernicus in patients with advanced heart failure and confirm a really amazing benefit. All of these 3 major trials became the foundation for the approval and acceptance of beta blockers as a cornerstone of the treatment of heart failure. So we had ACE inhibitors, we had beta blockers, and then people said, well, just about other neurohormonal factors. Well, we had aldosterone, we could use mineralocorticoid receptor antagonists to antagonize them. You could do that in mild heart failure on the left, severe heart failure on the right, reduce mortality, reduce cardiovascular hospitalizations. And then we kept going and we said, well, there are other neurohormonal targets. The response to beta blockers looked great. Response to MRIs looked great. Response to ACE inhibitors and angiotensin receptor blockers looked puny. So we said, well, we have to boost their effect. One way of doing that was to inhibit neprilysin because neprilysin broke down a whole host of compensatory vasoactive but also cytoprotective peptides. And we thought this would add to the neurohormonal antagonism. Neprilysin activity was increased in patients with heart failure, had adverse prognostic significance. We were able to link neprilysin with the renin-angiotensin system, and the first drug to ever do that was a drug called omapatrolat. And we thought this was the next step in neurohormonal blockade. Omapatrolat was a single molecule, inhibited ACE, inhibited neprilysin. There was only one little problem with omapatrolat. It was a twice-a-day drug. And the company wanted to make it a once-a-day drug. It inhibited ACE for 24 hours. It inhibited neprilysin for 12. And so when we did a trial with omapatrolat, we saw very little. And all of a sudden, neprilysin inhibition died as a concept. You can see the year here. This is 2002. From 2002, for the next 10 years, we ran around asking for support to do neprilysin inhibition for a 24-hour period of time instead of for 12. We thought that if we could do that, we would have a greater effect. If we didn't use an ACE inhibitor and we instead used an angiotensin receptor blocker backbone, we could get a combined effect with the system and neprilysin. And for 10 years, our pleas fell on deaf ears until we heard that Novartis had developed a drug that combined an angiotensin receptor blocker with a neprilysin inhibitor. They were going to give it twice a day, and they were going to develop it for the treatment of hypertension. And John McMurray and I flew to Novartis and said, you have to develop this drug for heart failure. And they said, omapatrolat didn't work. I said, we know why it didn't work. They say, you don't know why it didn't work. That's just a theory. And I said, well, please make an investment. Do a pilot trial. Do something. And the head of development at the time says, I'll tell you what. I'll make an investment in one trial. Just one. It better be a hell of a trial. And so this drug went into a trial of over 8,000 patients with ever having a phase 1 or phase 2 trial. Bizarre, but it worked. Sacubitril valsartan reduced cardiovascular death and hospitalization for heart failure by 20%, reduced cardiovascular death. Dose of enalapril was higher than any other dose of an renin-angiotensin system ever used. That was basically doubled the effect of the ACE inhibitor. And at the time that this came out, I had left cardiology for a decade. I had become a department chair in a department that had nothing to do with cardiovascular disease at the University of Texas Southwestern. And this was the only trial, only research in cardiovascular disease that I was involved in. I got to present this at the European Society of Cardiology in 2014, and I fell back in love with cardiology. And at the time, I went to the dean. I said, I don't want to be department chair anymore. I want to be a cardiologist again. Dean said, we don't have anyone to replace you. I said, that sounds like your problem and not mine. And as a result, I moved to Baylor. Anyway, this then became the cornerstone of therapy for many years. The neurohormonal hypothesis seemed to be very, very solidly supported, not uniformly supported. There were failures in the neurohormonal hypothesis. It was not perfect. But what the neurohormonal hypothesis did not answer was a critical question, which is how is activation of the sympathetic nervous system, renin-angiotensin system, aldosterone, how is that deleterious to cardiomyocytes? How does that happen? Oh, in Petri dish, put cardiomyocytes, put in angiotensin. Cardiomyocytes are unhappy. And so that was really the most amazing question about, because no one knew, no one understood. People could measure derangements. What could they measure? Well, they could measure oxidative stress markedly increased when you expose cardiomyocytes to angiotensin and norepinephrine. Mitochondria stop working properly. There's organellar dysfunction, not just mitochondria, a whole host of organelles. There's activation of pro-inflammatory pathways, and there is suppression of a biological process called autophagy. How many of you have ever heard of autophagy? Okay, very, very, I'm actually impressed. Autophagy is cellular housekeeping. All cells do it. All cells need to do it. All cells have been doing it for billions of years. It's enormously evolutionarily conserved. It can be done in a general manner. It can be targeted to organelles. And the only way that cells move and change their biological function is they have to do two things. They have to create new structures that are adaptive to an environment, but most importantly, they have to get rid of the old structures that no longer work. How do they get rid of the old structures? And the reason is they destroy them. And this is how they get destroyed. This is a cell. There is a dysfunctional mitochondria. You can tell the cristae are all over the place, really doesn't work. This mitochondrion is the source of enormous reactive oxygen-free radicals. It is causing an enormous problem. The cell has to get rid of this mitochondria and all mitochondria alike. And how does it do it? And the way it does it is it creates a double membrane vesicle, which targets the mitochondria, surrounds it, and isolates it, then fuses with a lysosome. The lysosome releases its degradative enzymes destroys the mitochondria, and that's how cells keep house. It's really an amazing process. ACE inhibitors promote it, beta blockers promote it, aldosterone antagonists promote it, but the drugs that really promote autophagy are SGLT2 inhibitors. Anyone who thinks that SGLT2 inhibitors work in heart failure because they work in the kidney probably has many friends who are nephrologists. I'm not going to tell you that they don't work in the kidney. They work in the kidney, but they don't work in the kidney for a very prolonged or sustained period of time because the kidney is unbelievably smart. And it counteracts the renal effects. But if you take a cardiomyocyte, expose that cardiomyocyte to an SGLT2 inhibitor, oxidative stress goes down, inflammation goes down, autophagy goes up, and guess what? There isn't a single molecule of SGLT2 protein in that cardiomyocyte. Benefit of these drugs on cardiomyocytes has nothing to do with the presence of SGLT2. You know that because I can take a mouse, knock out SGLT2, these drugs are still cardioprotective. And so that has opened up all sorts of horizons. These drugs look great in terms of reducing heart failure events in patients with type 2 diabetes. John McMurray, longstanding friend and colleague, led the DAPA-HF trial with dapagliflozin, showing very significant benefit on death and hospitalizations. At the same time, I was leading a sister trial with empagliflozin, also showing almost exactly the same effect on death and hospitalizations for heart failure. And all of a sudden, we had a new hypothesis for heart failure, which has been deemed the cellular stress hypothesis. By the way, none of the previous hypotheses are wrong. They are just imperfect. Heart failure is a sodium retentive disease. It's a hemodynamic disease. It's a neurohormonal disorder. It's a cellular stress disorder. The problem is not how you think about it. The problem is whether how you think about it influences new therapeutic development. That's the key. So this is how we treat heart failure now. This was the survival in 1975. This was the survival in 85, 95, 2005, 2015. And we've done a really good job in heart failure with a reduced ejection fraction. This is our challenge. This is what heart failure looks like today. This is heart failure with what people call preserved ejection fraction, largely obese, usually women, often hypertensive, who have a systemic inflammatory disorder that's transduced onto the myocardium, causes cardiac dysfunction, and that's our new target. All of cardiology, all of medicine, all of heart failure is storytelling. It's the stories we tell ourselves, it's the stories we believe in, it's the stories that dictate how we treat patients and how we look at the future. Most important thing is to realize that most of the stories we tell ourselves are wrong. We shouldn't believe in them as being a religious experience. They should last for about 10 or 15 years until someone smarter replaces them. And my current plan is to keep doing this for the next 20 years. Thank you so much.